Good evening, all the delegates.
Good evening, sir.
Good evening, all.
Good evening, sir.
Good evening, doctors. Today our topic is MRA, and today our speaker is Dr. Navin Agrawal. He is a well-known cardiologist in South Gujarat, and today our topic is MRA. So over to you, Navin sir. Over to you, sir.
Can I share my slides?
Yes, sir. Yes, sir.
Am I audible?
Yes, sir. Absolutely audible, sir.
My topic for today's discussion is regarding the use of mineralocortico receptor antagonist in heart failure management. How it has proven to be a boon in heart failure management, that we'll be going to be discussing. Basically, it's a question and answer scenario wherein we'll be discussing what exactly is our practice patterns, and I would be happy if the other people are also involved in the discussions. First of all, our topics, the objective of our topics are to gain insight on mineralocortico receptor placement and the utilization in heart failure management. Next is regarding the concern about hyperkalemia, whether it's really a concern in physicians' practice. And next is to create awareness amongst physicians regarding the use of mineralocortico receptor antagonist. First of all, heart failure. The global epidemiology of heart failure is that the prevalence of heart failure is around 26 million people worldwide. 1 to 2% of the adult population with heart failure is seen to have, in the developed countries, 1 to 2% of the total population is having heart failure. The prevalence increases with age and is rising to more than 10% among people with age more than 70 years. 8 to 10 million patients are of heart failure in India. The prevalence is 1% of the total population, or about 8 to 10 million individuals of India. The annual incidence is around 0.5 to 1.8 million new cases per year, and the mortality is around 0.1 to 0.16 million individuals per year. So it's a huge amount of mortality, huge amount of unmet need, and this mortality need is what needs to be addressed whenever we are talking about heart failure. So first question which should be discussing is, what percentage of the heart failure patients approach to you in stages NYHA class 2, 3 and 4? How many of the heart failure patients goes undiagnosed in India at an early stage, and why? Any comments? Perhaps in my practice, I see a lot more patients are in NYHA class 2 and 3 as compared to class 4. Can everyone mute their screens, because can you mute the participants, if at all possible? A lot of disturbances going on. In my practice, what I see is around maybe 30 to 40% of the patients in class 2 and class 3, while less than 10% of the patients in class 4. Usually the percentage of the patients who goes underdiagnosed or undiagnosed at an early stage is quite high in the Indian population, because our population tends to not to get the screening and the evaluation done, and very often they present to the doctor only when they are symptomatic. The trend of discussing the risk factors and the prevalence of risk factors and management of risk factors at an early stages of heart failure is less common in our patients. Usually most of the patients are referred to us only once they develop overt heart failure or severe heart failure, or in class 3 and class 4. Next is, what are the diagnostic and prognostic tools used by you for heart failure patients? For me, usually, of course, ECG and echo are the basic diagnostic tools, and to prognosticate also, most of the time we use ECG and echo, and besides that we use troponins. Sometimes to assess the viability, we can use a cardiac MRI. And of course, if the patient is having an ischemic heart disease, an angiography can also help as a diagnostic and a prognostic tool, and may decide the course of the treatment. Any comments by the participants?
What about the pro-BNP level?
Pro-BNP level is a prognostic marker mostly in acute heart failure. Usually, because of cost concerns, usually a lot of people are not using it on a routine basis. Of course, that is an important diagnostic marker and a prognostic marker, especially in the cases where we tend to get confused between the heart failure and a lung respiratory cause of a dyspnea. Of course, that is a very important diagnostic and prognostic tool. Routinely, what we are using is mostly the ECG echo. In doubtful cases, we are using pro-BNP, and angiography and other prognostic and diagnostic tools help us all along the way in the management of heart failure. Any other comments? So there was a 2021 update in the 2017 ACC expert consensus decision pathway for optimization of heart failure treatment, that caution should be exercised when mineralocorticoid receptor antagonists are used in patients. Serum potassium levels of the patient are more than 5, and if the patient is having a renal impairment with a creatinine levels of 2.5 in male and creatinine levels of 2 in women, these are the patients where ideally it's a concern where the use of mineralocorticoid receptor antagonist should be used with caution or maybe not used at all. How many people have seen clear-cut cases of severe hyperkalemia related to MRAs? And what percentage of your patients are going back home with heart failure with MRAs? Any comments? Usually, in my practice, I'm not seeing too often patients coming with severe hyperkalemia. Of course, beyond 2 creatinine, I'm seldom using MRAs, but only thing is that hyperkalemia with around 6.5 or 7 or 7.5 values requiring admission is less often seen. Usually, if you are careful about the creatinine values and you advise the dietary restrictions regarding potassium to the patients, usually very high values are not seen. But of course, if the potassium levels are on the high side, that needs to exercise caution, and we need to use MRAs on a less often in these patients. For routine patients with the creatinine values less than 2, I'm using it on a very routine basis. Only if the ejection fraction of the patient is completely normal, then I don't use it. Otherwise, majority of the patients, even with an EF although the guidelines say that the role of MRAs is mostly in the patients with an EF of less than 45, but I am also using them in patients with the EF between 45 to 50 also, or maybe 55 also. Beyond that, if it's normal, usually I'm not using. I'm using MRAs also a lot as an antihypertensive also in my cardiac patients. It's a very potent and a very good antihypertensive molecule, which is rather underused. Only if the potassium and the creatinine levels of the patient are normal, then it can be used in many hypertensive patients as well. Are these parameters, potassium levels, creatinine, and eGFR, tested before and after initiating MRAs, and how long? Usually in my practice, I often test these parameters before starting MRAs. Of course, everyone also would be doing. And once it is initiated, I think maybe after 1 month or after 15 days, once the patient comes back to the follow-up, especially in the patient with borderline levels and risk factors for heart failure, maybe like cardiorenal syndromes and things like that, these are the patients where you will be wanting to test it more frequent. Then what are the heart failure guideline recommendations for MRAs? As per the ESC guidelines in 2021, heart failure with reduced ejection fraction, mineralocorticoid receptor is recommended to reduce the risk of heart failure, hospitalization, and death. It's a class 1 indication. And in mildly reduced ejection fraction patients, it may be considered to reduce the risk of heart failure, hospitalization, and death. It's a class 2B indication. Heart failure with preserved ejection fraction, usually the role is not much, although there has been a few trials where it has been assessed, but the efficacy has not been proven as much. In reduced ejection fraction, of course, it's a class 1 indication, but with mildly reduced ejection fraction and in patients with normal ejection fraction, it may or may not be used. So this is a heart failure algorithm. If suppose you have a patient of heart failure with reduced ejection fraction, to reduce the mortality, we all know we use these line of drugs. We use an ACE inhibitor alternative. We use beta blockers. We use MRAs and SGLT2 inhibitors. I think MRAs and SGLT2 inhibitors both are being underused in a lot of patients, and the large majority of the patients don't go back with these molecules. Even as far as beta blockers is also concerned, the dose which the patient are receiving is very low. Usually, the majority of the patients are receiving very low, sometimes even placebo doses. And with ACE inhibitor ARNI, also many patients are going back with ARBs as compared to ACE inhibitors, predominantly because people are very afraid of the fact that the patient might come back with cough, and people tend to use ARBs much more often as compared to ACE inhibitors. That is what I have seen in routine practice. If at all you have to reduce the heart failure hospitalization mortality for selected patients, if the patient is having volume overload, you give the patient diuretics. Suppose the patient is having sinus rhythm with an LV morphology with a QRS duration of 150 milliseconds. If the patient is having a ischemic etiology, it might be considered for AICD. If the patient is having atrial fibrillation, he might be planned for anticoagulation. Atrial fibrillation, you might give the patient digoxin and other pulmonary vein isolation technique, that is the 3D mapping technique. And if the patient is having aortic stenosis, you may consider the patient for surgical aortic valve replacement or TAVI. Mitral regurgitation might be considered for a patient for TE guided MV repair. And patients with a heart rate more than sinus in the sinus rhythm, if the heart rate is more than 70 beats per minute, we consider the use of ivabradine as an adjunct to beta blockers or as an alternative if it's contraindicated. In patients with sinus rhythm with LV morphology with QRS duration of 130 to 149 and non-LV morphology with a QRS of more than 150 CRTD can be considered. In a non-ischemic etiology, ICD might be considered also if the ejection fraction is low. In coronary artery disease, we consider CABG, and if the patient is having iron deficiency, we add ferric carbon oxymaltose. If the patient is having black race, then he's a candidate for isosorbide hydrolyzing combination, which also perhaps is a very underused molecule. Hardly I've ever seen anyone else prescribing these molecules except for me in a routine practice. ACE inhibitor and RNA intolerance, if the patient is having, then you prescribe the patient's ARB. In our practice patterns, irrespective of the word, the guidelines say we start the patient with ARBs, and that too with telmisartan, olmesartan, and azilsartan. These sartans, I must tell you, should have no role in any heart failure management, and rather every patient with heart failure should go back with either ramipril, perindopril, or enalapril, or something like that, or ARNI. And if at all the patient is intolerant, the only sartans which are recommended is losartan, valsartan, and candesartan. The other sartans have no role in heart failure management as of now because they have no trial evidence. For selected advanced heart failure patients, we consider them heart transplantation, but because of logistic concerns, I think as of now, and maybe in the next few years also, heart transplantation will be a very uncommon option because of cost concerns, logistic concerns, and because of the long-term cost and other problems. In some patients where the patient is not a candidate for cardiac transplantation, then you can consider the patient for a mechanical circulatory support device. But again, also this is a very costly affair, and usually that is only considered as a bridge to transplantation, not as a destination therapy. To reduce heart failure hospitalization and improve the quality of life in all patients, we consider the patient for exercise rehabilitation, and usually we give the patient professional disease management support. In what percent of patient do you use a mineralocorticoid receptor antagonist for heart failure management? In my practice, I think except for contraindicated patients, I'm using it in almost 100% of the patients, especially if the EF is less than 45%. More than 45, maybe depending on the symptoms. And usually I consider starting a mineralocorticoid receptor antagonist in patients with heart failure along with ACE inhibitors and beta blockers. My patient on day one of admission at the hospital, I started as soon as the patient is in the hospital. Only if the creatinine values and potassium values are high, that I consider as a contraindication, and these patients I hold this. Otherwise, at the time of admission only, I usually initiate all these molecules along with ACE inhibitor in ARBs and beta blockers and with SGLT2 inhibitors. 99% of my practice patients also go with SGLT2 inhibitors also in heart failure patients. Any comments by the participants? What are your practice patterns?
We generally use it, but do you prefer it to use it with loop diuretic?
Usually, I see one thing is very clear that loop diuretics only is for achieving a euvolemic status. Loop diuretics have no mortality benefit.
Right.
So only majority of the patient ideally should go only with aldactone, and if at all there is some hypervolemic status, then only loop diuretics should be prescribed, and that too for the shortest duration of
Short
time as
duration,
possible,
yes,
because loop diuretics activate the renin-angiotensin system. So if at all we are prescribing this, it is only for first 10 to 15 days until the patient is hypervolemic and volume restriction is not sufficient to maintain a euvolemic status. Till that time, I think loop diuretics should be added on. बहुत सारे पेशेंट्स का आई सी प्रैक्टिस पैटर्न की सब लासी लैक्टोन ही लिखते हैं या सब डाइटा प्लस ही लिखते हैं. That is, I think, a wrong practice, because अगर hypervolemic नहीं है पेशेंट तो लासिस वाला कंपोनेंट का कोई मतलब नहीं है. आप पेशेंट को खाली फ्लूइड रेस्ट्रिक्शन करते हो तो आई थिंक दैट इज सफिशिएंट. मेजॉरिटी ऑफ द पेशेंट्स को हम फ्लूइड रेस्ट्रिक्शन बोलते नहीं है और सबको लूप डायरेटिक दे देते. तो आई थिंक दैट इज अ स्लाइटली अनयूजुअल थिंग. एंड besides, मुझे lacilactone combination also I'm slightly hesitant with, because that contains lasix 20 and aldactone 50. For majority of the heart failure patients, I think aldactone 25 is sufficient. So that is an unusual combination जहाँ loop diuretic का component बहुत कम है और aldactone का component बहुत ज्यादा है. तो incidence of hyperkalemia will be more with this combination. And if at all diuresis हमको चाहिए तो loop diuretic action बहुत कम होगा, because 20 milligrams of lasix is equivalent to 5 milligrams of diator. So बहुत ज्यादा low potency हो जाएगा. तो if at all I think diator plus or this sort of combination is slightly better if at all heart failure management में use करें, because the potency of the loop diuretic for achieving U volume is slightly more in this combination. That's what I tend to use as compared to lacilactone combination.
What is the potassium level you prefer? For an example,
usually potassium levels below 5.
Below 5, okay.
Below 5. If at all potassium level is above 5, we have to use it with caution. Till 5.5 also I am going with MRIs routinely, but that requires monitoring. और अपने यहाँ सर पेशेंट का प्रॉब्लम क्या होता है कि पेशेंट रेगुलरली पोटेशियम करा के बार बार आते नहीं, और वंस इन वाइल ऐसा होता है कि 3 महीने 6 महीने में सडन कोई हाइपरकैलेमिया के साथ आए. बट लकीली अभी तक मुझे कोई ऐसा पेशेंट नहीं मिला इतने साल में कि जिसको 7.5 और 8 पोटेशियम लेके आए और बाद में अफसोस हुआ हो कि aldactone दिया हो. सालों में एक आधी.
Yes, many of our OPD patients, they come with potassium 5.5 to 6. In such cases, we can continue with pyranol.
Usually, in that cases, we should go low. 5.5, 6 है तो I think avoid करना चाहिए. Guidelines के हिसाब से 5 के हिसाब से we have to be above 5. We have to be cautious. 5.5 अगर मॉनिटरिंग अच्छी हो सके तो दे सकते हैं, पर 6 तो I think is too high. 6 पर तो नहीं देना चाहिए, क्योंकि 6 पर अगर दिया और फिर पेशेंट अगर सडन CHB और हार्ट ब्लॉक के साथ आता है या कार्डियक अरेस्ट में जाता है तो दैट विल बी अ negligence issue. So usually 5.5 is the upper limit, and even with 5 to 5.5 also, if only good monitoring can be done, then only I think that should be initiated. Less than 5, of course, there is nothing to be worried about. सिर्फ only creatinine also has to be considered, because कई पेशेंट हमारे ऐसे होते हैं जिसमें creatinine levels 1.5 1.6 होता है, भले पोटेशियम ठीक हो तो वहां पे भी थोड़ा सा ऐसा होता है कि हो सकता है फॉलोअप में पेशेंट माइट कम विद सिवियर हाइपरकैलेमिया. So if the renal function is good, then there is no worry. But if the renal function is borderline or compromised on elderly patient, then that might be a tricky issue, because in that case hyperkalemia might be slightly dangerous.
And what is your preference, pyranol or eplerenone? We don't have any experience in eplerenone. We generally use pyranol.
Eplerenone, as of now, frankly, I am using only in cases where there is gynecomastia in male patients because of cost concerns. Eplerenone I have been using in a lot of cases, but only in patients जैसे 5 to 8% cases of aldactone patient में मेल में gynecomastia होता है, तो उसमें I am using eplerenone just because of cost concerns, because aldactone is only 2 rupees, eplerenone is 25 rupees. So patient का cost के हिसाब से it becomes a difficult issue, because usually majority of my patients will be on ARNI also, will be on dapagliflozin also, beta blocker भी high dose रहेगा, तो cost of therapy बढ़ जाता है. Usually अगर cost के वाइज सोचे तो I usually tend to prefer aldactone much more as compared to eplerenone, just because of cost concern. ऐसा नहीं है कि eplerenone is a bad molecule. Of course, it is a better molecule, but only thing is कि cost is a prohibitive concern in eplerenone.
And in case
of sir, one question more. If the potassium level is high and if you stop the aldactone, so when to repeat the potassium level? First question. And suppose you come down normal with K-bind or whatever you give, or diet control or anything, and again we can start aldactone, or we temporarily or permanently we have to stop aldactone?
Ideally, we can start. Ideally, if the renal function is good, then we can start. हाँ, अगर पेशेंट को डेंजरस हाइपरकैलेमिया हुआ है कि पोटेशियम हैज गॉन बियॉन्ड 6.5 और 7 के आसपास पहुंच गया, देन वी शुड अवॉइड एटलीस्ट फॉर 6 months.
नहीं वो हो गया, 7 हो गया, हमने डाउन कर दिया, 5 पे 5 अंडर 5 ले आए, then we again start the aldactone, or we cannot start again?
Ideally, beyond 6.5 we should not start it. अगर ट्रांजिएंट किसी को,
my question is, suppose पेशेंट का हमने aldactone चालू किया है, पेशेंट का पोटेशियम आया 6.6 आया, we stop the aldactone, repeat the aldactone after 3 days after treating it, if it becomes now 4.5, can we again start aldactone or not?
Not start at least for 6 months. I would not start it for the next 6 months
Exactly.
at least.
That's what I want. Okay.
Because
Thank you.
जब तक अगर creatinine levels normal नहीं आ जाए तब तक it will not be very wise to restart it. अगर
Okay.
dangerous levels आया है 5.5 I'll be comfortable with. 6.5 से ऊपर गया है तो I will put a note in my OPD paper and that patient I will be less, unless absolute indication है कि patient severe heart failure का है, बहुत ज्यादा खराब EF है 15-20 EF है तो then I'll be restarting. अगर 45-50 वाला EF है तो then I will leave it और उसके बाद I'll not restart it again. अगर बिल्कुल बॉर्डर लाइन वाला है तो I'll not restart it. अगर बहुत खराब है, compelling indication है, then after 6 months or 4
benefit
months,
is more than that, then we can definitely go ahead with that.
Yeah.
Okay. Thank you.
There is something which is known as aldosterone escape in congestive cardiac failure. Importance of the time of initiation of mineralocortico receptor antagonists on the risk of mortality with heart failure. This was the article. Use of mineralocortico receptor antagonist should be done as early as possible on top of the basic treatment, including ACE inhibitor, ARB, and beta blockers, preferably at the time of discharge after an episode of decompensated heart failure. Following an acute fall in aldosterone in response to the administration of ACE inhibitors, the level of aldosterone rises again and indeed returns to the baseline in almost all patients, which is known as aldosterone escape. Even with an ACE inhibitor, if it is given in combination with an ARB, aldosterone levels remain uncontrolled. Aldosterone escape might promote the release of angiotensin II via a positive feedback loop that stimulates the ACE inhibitor in the vasculature. This progressive escape of the aldosterone is thought to contribute to AC resistance, whereby the effect of AC inhibitor also becomes blunted and beneficial effects of mortality decrease over time. Whereas with mineralocortico receptor antagonist, they are able to antagonize the deleterious effect of aldosterone, resulting in a beneficial effect on patient mortality. So this is an important fact कि सिर्फ isolated ACE inhibitor अगर हम दे रहे हैं patient को तो aldosterone levels बढ़ जाएगा और जितना intended benefit है वो नहीं मिलेगा. So overt heart failure का patient है, EF less than 30-35 है, definitely all of them should have a mineralocortico receptor antagonist along with an ACE inhibitor. Isolated ACE inhibitor का उतना ज्यादा benefit नहीं होगा अगर हम उसको MRA के साथ में नहीं दे रहे हैं because of the phenomena of aldosterone escape and positive loop feedback of the rise of aldosterone once we are using ACE inhibitors. There was another article where spironolactone and eplerenone were compared in patients with LV systolic function in chronic heart failure. This is a study from Bangladesh, not a very big trial. They have done around 224 cases and they have compared one arm with spironolactone and aldosterone and have used the echocardiographic criteria to see the systolic and interstitial volume, and they have found that eplerenone is better as compared to aldosterone. That is what spironolactone, that is what they have found. But I think that should be taken with a pinch of salt because not a very big trial, not a big population group, and criteria is only echocardiography, which might be subjective and the results might be varying from one echo to another. So I'll not be very intended to grade eplerenone better as compared to spironolactone just on the basis of this trial, which is not a very big randomized trial and not a very big trial per se. Any comments? Are you people using aldactone or eplerenone, and what is your experience on these? Okay. So when do you prefer using eplerenone and spironolactone? Any specific patient population? Of course, all patients with systolic heart failure. I tend to use these molecules. Start with spironolactone. If the patient, especially a male patient, develops gynecomastia, I switch over the patient to eplerenone. Just because of cost concern, I don't say that eplerenone is a bad molecule, but only cost concerns. Because of cost concerns, I'm more obliged to write spironolactone as compared to eplerenone. The dose adjustment protocol proposal for hyperkalemia patients. If at all the patient is having a potassium level less than 4, we increase the dose of spironolactone from 25 to 50. And if the dose, if the patient is having a spironolactone on alternate days, 25 mg alternate days, then we make it 25 mg daily. If at all we are using eplerenone, we use it, increase the dose from 50 milligrams to 100 milligrams per day. Similarly, for 4 to 5.4, no adjustment is required. For potassium levels between 5.5 to 5.9, we decrease the dose from 50 to 25. And if at all the patient is already on 25, we make it an alternate day preparation and we monitor the potassium levels within 1 week. Similarly, for eplerenone levels also, we make it half. If the potassium levels are more than 6, we stop the treatment, reassess the potassium, assess the potassium after 1 week. And when the potassium levels are less than 6, we initiate a K binder and reintroduce MRA. I think initiation of a K binder for a long-term therapy is rather not practical because of the cost concerns again, and K bind sachet to be using on a regular basis is not a very good option. I don't think that. But I would, if a potassium level is more than 6, I would be slightly skeptical in restarting MRAs, at least for the next 4 to 6 months. Similarly, for epinephrine also, they are proposing the same therapy. And if at all the eGFR is less than 30 mL per minute, we stop the MRA and reintroduce upon a clinical decision upon the function of upon the renal function improvement and potassium level stabilization. This is what I was discussing, because transient the patient might be having hyperkalemia and potassium might go up to 6.5 or 7 also. But once the creatinine stabilizes, then the concerns are lesser, and then we can again give it a trial. But again, here I will be more concerned that if at all the patients are having a severe LV dysfunction, only these patients I will reinitiate the MRAs. If the EF is around 40-45, I think better we can avoid it and use other SGLT2 and other safer molecules which are less toxic. Maybe after once the patient is long-term into follow-up, maybe 1 year, 2 years down the line, then you can again restart it slowly. Start with a half dose and then again monitor the potassium levels. That's what I would think should be the strategy. Providing the renal function is stable and eGFR values are more than 30 ml per minute and BP stable with a systolic BP of above 100 mmHg. This is also important that this is an antihypertensive molecule, so the BP level should be more than 100. If at all the BP level is less than 100 and very severe LV dysfunction patient, then the patient might deteriorate after starting MRAs and the BP might fall slightly, and the patient might go into sudden renal deterioration also because of hypoperfusion. So in patients with BP levels less than 100, I think we should be more cautious in starting these molecules, because some BP reduction will be there once we start this molecule. The next question is, what is the preferred dose and how is the dose titration carried in your practice? My preferred dose for both these molecules is 25 milligrams, and I usually don't up titrate. That is what I usually do. We can up titrate from 25 to 50 for spironolactone and epinephrine, but usually I am not very fond of up titrating just because of the fact that potassium levels are slightly more difficult to monitor in our patient population. Majority of the patients I do go with 25 mg daily basis. If at all the potassium levels is on slightly on the high side, I make it alternate day, but I seldom recommend going for 50 mg daily, because if at all you are very confident of monitoring the potassium, then it is okay. But that is slightly tricky in our population, because the hyperkalemia prevalence, as you can see in this slide, is around 9.3%, and out of which 54% was attributed to MRA. So 9.3% hyperkalemia is slightly on the higher side only. So I would be either skeptical in going over for a very high dose of MRA. What percent of the patients of MRA develop hyperkalemia and do they require discontinuation of the therapy? I think less than 2-3%. That's what I feel. If at all the creatinine level is okay, creatinine level is around 1, then the incidence will be less than 5%. If it is more, in my practice, creatinine levels, then I will be slightly skeptical, and potassium levels might go up if the creatinine levels is more than 1.5. And if at all, what percent of the patient, how these patients manage? Usually we give the patients K binder, then stop aldactone for some time, then reassess the patient, reassess the renal function, and restart if at all it is required and absolutely required. Then we can do it. Now, this is another article where the timing of epinephrine initiation and outcomes of patients was in acute myocardial infarction complicated by acute LV dysfunction. This was the insights from the FSS trial, which was a big trial of 6,000 patients. And they found that the earlier epinephrine administration improved the outcomes in patients with LV systolic dysfunction and heart failure. This benefit was not observed when the epinephrine was initiated more than 7 days later. So one thing is important for all heart failure patients, that all heart failure therapy has to be initiated at the time of admission. Majority of the times होता क्या है कि हम पेशेंट को घर भेज देते हैं, 10-15 दिन के बाद बुलाते हैं और फिर रीस्टार्ट करते हैं. तो यूजुअली ज्यादातर कार्डियक रिमॉडलिंग फर्स्ट 1 month ऑफ मायोकार्डियल इंफार्क्शन में होता है. इस टाइम पे इफ द पेशेंट इज नॉट कवर्ड, उसको SGLT2 इनहिबिटर्स नहीं मिल रहा है, उसको एल्डेक्टोन नहीं मिल रहा है, उसको बीटा ब्लॉकर्स नहीं मिल रहा है, AC इनहिबिटर्स नहीं मिल रहा है, देन नेगेटिव रिमॉडलिंग जितना होना है वो फर्स्ट 1 month में काफी हो जाता है, और समटाइम्स द डैमेज इज इरिवर्सिबल. So as early as possible you started, and ideally I started at the day of admission only. But if at all the BP is a concern, especially in my post-plastic patients where I don't want the BP to fall less than 120 in a majority of these cases, because the incidence of stent thrombosis rises once the BP falls. So in my patients, I'm slightly skeptical in beta blocker. Instead, I use of beta blocker. I tend to prefer ivabradine, and I give the patient SGL2 to Aldactone and very low dose of Ramipil. Once the patient comes back after 10 days, then I start beta blocker if the BP is on the borderline. So this is another graph where they have shown that early administration of Epinephrine within 3 to 7 days improves the outcomes in LV systolic dysfunction post myocardial infarction, and the absolute mortality reduction, the relative mortality reduction was 31% in comparison to placebo when initiated before 7 days versus after 7 days. And the incidence reduction of sudden cardiac death was also 34% with Epinephrine as compared to placebo, and it was better when initiated early. So 34 and 30% is a huge mortality benefit, because if at all we consider that the absolute mortality risk after a myocardial infarction, even after angioplasty, will be around 8 to 10%. So 30% benefit will be around 2 to 3% we will be saving once we are using MRAs. And the number needed to treat for MRA is very low. You hardly need to treat 31 patients to save one life. So that is very low. 30 patients agar aap treat karte ho, every 100 patients you are treating on a monthly basis, you can save 3 extra lives by initiating MRAs early. So that is a huge amount of benefit. और बाकी सारे patients को भी at least LV function में improvement तो मिलता ही है. So I think it's a big thing which, if we are missing out on this, it has to be initiated as early as possible if at all the creatinine and the potassium levels are stable. Now the next question is, in clinical practice, how early are MRAs initiated for management of patients with heart failure? I think as early as possible. Usually this is the algorithm. Management of patients with HFrEF, we give the patient ACE inhibitors, beta blocker, MRAs, dapagliflozin, loop diuretics. If the EF is less than 35 with the QRS of less than 130, we give the patient AICD. If the EF is more than 35, or when the device therapy is not indicated, then we continue with the medical management, and if the symptoms persist, then we go with class 2 recommendations. If the patient is in sinus rhythm with an LV of less than 35 with a QRS duration more than 130 milliseconds, then we can consider the patient for a CRT therapy if the QRS is wide. But usually the success ratio of CRT is not 100%, is around 60%. And because of cost concerns, we are not using CRT on a regular basis. Now the next question is, at what stage of heart failure diuretics and MRAs both are needed? I think at early stages, when the patient is hypervolemic and comes to you in acute heart failure, that time both are indicated. And then once the patient becomes euvolemic, then you can taper down the diuretics and continue with the MRAs. Ideally, the combination of both these therapies should be initiated only in the first few days in a hypervolemic patient. And once the patient comes back and becomes euvolemic, continue the patient only with fluid restriction and stop torsemide. That is what I do. Any other comments from the participants?
What about the cases of postpartum heart failures?
Postpartum heart failure, I don't initiate Aldactone, because Aldactone safety has not been proven in patients who are breastfeeding. If at all the mother has stopped breastfeeding, then we can start. But if at all breastfeeding कर रही है, तो I will go very slow, because breast milk में अगर secrete होता है and fetal kidney पर कोई damage होता है या fetus या baby को कोई hyperkalemia होता है breastfeeding के दौरान, तो then it becomes a problem. So अगर mother feed कर रही है, तो उस time पे I'll not be confident in starting epinephrine. Only diuretic, only beta blockers, cardioselective beta blockers, no ACE inhibitors, no MRAs, no SGLT2 inhibitors. जब पेशेंट, या तो मैं तो यूजुअली मदर को ये बोलता हूँ कि ब्रेस्ट फीडिंग बंद कर दो, पेशेंट को, बच्चे को टॉप फीड पे ले लो, एंड देन वी स्टार्ट ऑल दीज मॉलिक्यूल्स, because breastfeeding mein the safety is not documented. So I'll be very concerned if at all the mother is still feeding, then I'll be very concerned in starting these therapies. So now the question for all the panel members, in your practice, any other indication apart from heart failure where you are using MRAs? I think I'll be using a lot more in cardiomyopathies and also in patients with valvular heart disease also, जहाँ overt heart failure नहीं भी हुआ हो. Suppose mitral stenosis का patient है, we know कि patient को कभी ना कभी tachycardiomyopathy develop होगा. There I'll be using. Cardiomyopathies में जहाँ LV hypertrophy है, there I'll be using, because LV hypertrophy reduction में role है. Hypertension we are using, uncontrolled hypertension is a good molecule अगर patient को CKD नहीं है तो. और besides, any other thoughts? where you are using MRAs?
In any case of acute MI,
Acute MI, of course, heart failure is there, then we'll be initiating, because that is predominantly we are treating for heart failure. The question was for beyond heart failure. Beyond heart failure, I think for isolated hypertension मैं use करता हूँ, पर cardiomyopathy में भी use करता हूँ. Hypertrophic cardiomyopathy के सारे patients में I'm using it. I'm not sure कि there is proven indication है. Beta blockers का तो definitely है. Aldosterone I'm using just कि fibrotic anti-fibrotic effect होगा और maybe a certain cardiac death का incidence कम हो जाएगा. इसलिए cardiomyopathies और valvular heart disease में भी I'm using routinely. वहाँ पे I'm using SGLT2 inhibitors also, although it has not been tested. But in valvular heart disease and cardiomyopathy patients also I'm using SGLT2 inhibitors.
there any role in concentric LVH?
Any role in concentric LVH? Sir, we can. I think we can. Because अगर patient को LV hypertrophy है तो definitely diastolic heart failure का candidate तो हो ही जाएगा.
और young age hypertension.
I think we can, क्योंकि अगर LV hypertrophy significant है, at least अगर disproportionate है तो करना ही चाहिए. अगर disproportionate नहीं भी है तो भी अगर patient को देना है और ACE inhibitor beta blocker दे रहे तो साथ में I could be cocktail के हिसाब से देना में बुरा नहीं है, because anti-hypertensive effect भी है और थोड़ा सा hypertrophy भी कम किया तो that is good for us. Diastolic heart failure का chance कम हो जाएगा. I think we should.
Decompensated cirrhosis of liver, though I have never used it.
Cirrhosis, it is a patient of hyperaldosteronism. Cirrhosis में the doses जो gastroenterologists use करते हैं, that is beyond, मतलब 100, 200 का dose use करते हैं. Actually जो lacilactone का combination था वो mainly cirrhotic के हिसाब से बनाया गया है, क्योंकि lacix कम लगता है, aldactone ज्यादा लगता है. पर cirrhosis, I think there is clearly indication, because cirrhosis में भी fibrosis बहुत ज्यादा होता है, तो cirrhotic patients में use करना चाहिए. Hyperaldosteronism होता है cirrhosis में, तो I think gastroenterologists are using very frequently in cirrhosis.
Periodic paralysis, hypokalemic periodic paralysis.
That is also very good, very correct. I had forgotten this indication. That is also very. अगर IHPP का patient आता है तो definitely देना चाहिए, क्योंकि
hirsutism is also another indication for using spironolactone.
Hirsutism, okay. What are the scientific initiatives you should suggest to CIPLA for increasing the awareness among the practitioners about MRAs? I think more of these discussions can be done, because majority of the time होता ही है कि we are not discussing upon this, इसलिए we are not using this also, because these molecules are less often promoted. ज़्यादा indications पर भी बात नहीं होती. Trial data भी बहुत ज़्यादा नहीं है. Only 2-3 trials are available. So I think more trials should be done, more data should be brought in majority of the new patients, जैसे cardiomyopathy we were discussing, periodic paralysis का patients है या valvular heart disease के patients है, वहाँ पे more data can be brought in, and that can bring more awareness in the minds of the doctors, or regular academic discussions can be done on this topic. I think it is rather a topic which is not discussed. मुझे इतने साल में I think MRAs पे I think I am doing my first CMA on MRAs in so many years. So I think it is a rather under touched topic. That's what I feel. Any comments, sir?
Thank you. That I want to know about the role of sigma. You use it regularly in heart failure patients?
Definitely, sir. Definitely, sir. है अच्छा खासा रोल. Only concern is cost. से आर्नी का बहुत अच्छा रोल है, लेकिन प्रॉब्लम अभी क्या है कॉस्ट का. सर अभी रिसेंटली मैंने क्या किया है सर, जब से ये जायो वाला कॉम्बिनेशन आया, मैंने काफी पेशेंट में हाफ ओडी ट्राई करना चालू किया था. पहले तो ये था कि हाफ बीडी देते थे कॉस्ट बचाने के लिए. अभी काफी पेशेंट में मैं हाफ ओडी ट्राई कर रहा हूँ, वो काफी कॉस्ट इफेक्टिव होता है. तो अभी मैंने काफी ज्यादा पेशेंट में देना चालू किया है. रादर देन गिविंग अदर मॉलिक्यूल्स, अगर आप आर्नी दे पा रहे हो, भले हाफ ओडी डोज में दे रहे हो, तो कॉस्ट बहुत कम हो जाता है. 1200 रुपए का डोज हो जाता है पर मंथ का. तो दैट इज क्वाइट अफोर्डेबल.
Many of patients they develop hypotension with that dose.
हाइपोटेंशन है सर. आर्नी इज अ वेरी पोटेंट मॉलिक्यूल. हाइपोटेंशन तो होगा, पर अगर बीपी अच्छा है तो उससे अच्छा कुछ नहीं देने को, क्योंकि अभी तक जितना डेटा अवेलेबल है आर्नी का और SGLT2 का, आई थिंक ये मॉलिक्यूल्स तो देना ही देना चाहिए. अफोर्डेबल पेशेंट है तो डेफिनेटली देना चाहिए. मैं अभी रिसेंटली ये प्रैक्टिस जो चालू किया है, इसमें हाफ ओडी दे रहा हूँ मैं खाली. ऑल्दो बायोअवेलेबिलिटी थोड़ा कम होगा, डेफिनेटली आई अग्री टू दैट. बट प्रॉब्लम ये है कि पेशेंट अगर डबल डोज भी देते हो तो पेशेंट आधे से ज्यादा तो बंद करके बैठ जाते हैं कॉस्ट की वजह से. तो मुझे लगता है कि कुछ नहीं देने से तो कुछ देना अच्छा है.
SGLT2 inhibitor, if patient is not having diabetes, then also you can use.
मेजॉरिटी मैं तो बहुत पेशेंट में दे रहा हूँ सर. नॉन डायबिटिक्स में बहुत सारे पेशेंट हैं मेरे. एटलीस्ट 1000 से ज्यादा पेशेंट्स होंगे जो नॉन डायबिटिक हैं और SGLT2 पे है. सर एनी हार्ट फेलियर, अगर पेशेंट को सिस्टोलिक आया है और डायस्टोलिक में भी, अभी जो एम्पा प्रिजर्व का ट्रायल आया है, इट इज द ओनली मॉलिक्यूल जिसका डायस्टोलिक हार्ट फेलियर में स्टैटिस्टिकली सिग्निफिकेंट डायस्टोलिक हार्ट फेलियर में बेनिफिट है. तो अगर कोई पेशेंट आपको एक्सर्शनल डिस्निया वाला मिल रहा है जहां यू थिंक कि डायस्टोलिक हार्ट फेलियर हो सकता है, सिस्टोलिक फंक्शन नॉर्मल भी है, वहां पे भी देना चाहिए, और सिस्टोलिक डेफिनेटली खराब है तो देना ही देना है सर. तो नॉन डायबिटिक्स
Start with
में
DAPA 5 milligram.
10 सर, 10
10.
10 इज द स्टैंडर्ड. अगर 10 टॉलरेट नहीं करेगा तो देना चाहिए, बट 10 टॉलरेट नहीं करने का कोई रीजन नहीं है, क्योंकि इतना पोटेंट हाइपोग्लाइसेमिक वो है तो नहीं. सिर्फ यूटीआई का एक प्रॉब्लम आता है सर, बाकी कोई प्रॉब्लम नहीं आता मोस्ट ऑफ द टाइम्स. मेरे एक दो पेशेंट में ऐसा हुआ कि वो बोल रहे थे कि एपेटाइट बहुत बढ़ जाती है, क्योंकि शायद बेसलाइन एक हाइपोग्लाइसेमिक लेवल क्रिएट हो जाता है, 70-80 का शुगर लेवल हो जाता है, तो भूख ज्यादा लगती है, ऐसा कुछ लोग कह रहे थे. और कुछ लोगों में बहुत ज्यादा वेट लॉस होता है. तो अगर ओबीस पेशेंट है तो आई एम यूजिंग इट वेरी ऑप्शन, क्योंकि वेट रिडक्शन में भी थोड़ा हेल्प हो जाता है. मैं पेशेंट को पहले ही बोल देता हूँ कि 5-6 किलो वजन कम होगा, अच्छी बात है. पर नॉन ओबीस पेशेंट में कई बार ये थोड़ा सा दिक्कत हो जाता है कि पेशेंट का 8-10 किलो वजन कम हो जाता है, तो पेशेंट कई बार कंसर्न हो जाता है कि वेट लॉस हो रहा है. एक तो वैसे ही हार्ट फेलियर से वेट लॉस होता है, ऊपर से SGLT2 से भी थोड़ा और हो जाता है, तो पेशेंट कई बार कंसर्न हो जाता है. पर अदरवाइज आई थिंक इट्स अ गुड मॉलिक्यूल, देना चाहिए.
Thank you.
Okay. Any other comments by other audience?
Thank you so much, all the delegates. Any question regarding this session, please ask to doctor.
Thank you. It was very informative lecture.
As a wonderful session. Thankful to Dr. Bhavik Shah from Baroda, Dr. Darshan Chaya from Baroda, and Dr. Navin Agrawal. Very thankful to you, sir, as a wonderful session. And thank you so much, all of you. And good night. Thank you so much, all of you.
Thank you. Thank you.
Such a wonderful session. Thank you so much, all of you.